Hello, my friend. What's up? On this episode, I continue my conversation with the world expert on lipids, Dr. Tom Dayspring. We dive a little bit deeper into cholesterol. We discuss what causes heart disease, and we discuss how to lower your bad cholesterol numbers, such as LDL cholesterol, some of the ratios, ApoB, and even triglycerides. We touch on what you can also do naturally using either diet, lifestyle, or supplementation to reduce some of these numbers. If you're interested in heart health, and my friend, you should be because that is the number one killer in this country, then you got to listen to this episode front to back. If you're enjoying this show, please make sure to hit the subscribe button down below so you can get notified when we release new episodes. Our goal is to help you slow down your aging and look and feel younger. Okay, so let's dive right into part two. And let's start with, what do you want to start with, Tom? Should we start with LDL or cholesterol?
Yeah, we've concentrated so much that ApoB is the real criminal. We have to do that. But I've also hinted that in most cases, LDL cholesterol, total cholesterol, non-HDL cholesterol correlate nicely with ApoB. But let's just briefly talk about the circumstances where they do not. Who's got a high cholesterol but a normal ApoB? Who has a perfect cholesterol measure but has a real ugly ApoB? When those metrics agree with each other, they are said to be concordant. They agree with each other. But what is the circumstance where one is high and the other one is low? They would said to be discordant. And we know through multiple studies now that when particle numbers, ApoB, LDLP, are discordant from cholesterol metrics, LDLC, non-HDLC, risk always traffics with the particle number in a more accurate fashion. So if you tell me, hey, my LDLC is perfect, but you also say, but I don't know, my ApoB is through the roof, my LDLP is high, I'm really worried about you. So once you understand that concept, and that's, by the way, how people do die with normal LDL cholesterol, they have high ApoBs, or why not everybody with high LDL cholesterol necessarily needs a drug or even a specific lifestyle to lower it. Because if they don't have high ApoB, they're not at risk for any of these diseases. So remember, what is LDL cholesterol? It's the mass of cholesterol within all of the LDL particles in your bloodstream. So what determines that? Well, I'm extracting cholesterol from every molecule and weighing it. So what determines in every LDL particle how many cholesterol molecules are in there? The first, and it's pure geometry. Big LDLs carry more cholesterol molecules per particle than do the very small LDLs. By the way, small, less lipids. It sinks in a centrifuge tube. That's why you hear small, dense. They're redundant terms. Just say all small lipoproteins are dense, all big lipoproteins are buoyant, and they're not dense. So there's no need to say small, dense. It's, you're redundant with that. So it's a little pearl I like to hammer home. So anyway, if I have a bunch of large LDL particles, my LDL cholesterol is going to be high. But the volume of a sphere is a third power of the radius. So when you start changing particle diameter, there's tremendous discrepancies. So you might have a lot of cholesterol molecules because all you got is big LDL particles. But if you actually counted the number of particles, it's physiologic. So those are people with high LDL cholesterol, but no high ApoB or LDL particle counts. Despite their elevated LDL cholesterol, they're not at terrible risk for atherosclerotic heart disease. What else would influence it other than the size of the particle? And this is what's really going on in our world. LDLs, I hinted before, are meant to carry cholesterol. What are they not meant to carry? Triglycerides. Normally, a physiologically normally composed LDL particle has 80% cholesterol molecules, 20% triglycerides or less. It's a 4-to-1 ratio. But what if your LDLs, for whatever reason, are full of triglycerides? If they are, what is there no room for that LDL to carry? Cholesterol. So triglyceride-rich LDL particles are necessarily cholesterol-depleted LDL particles. So if that person has, say, an LDL cholesterol of 100, which seems good, because each LDL particle can only carry drastically less cholesterol molecules, you would need a ton of those LDL particles. So as triglycerides start to escalate, LDLs both become small and they become triglyceride rich, which requires way, way, way more LDL particles. So as triglycerides goes up, you get discordance between LDL cholesterol and ApoB. So that's the most common instance of who's got these wonderful LDL cholesterol levels, but they're all in the CCU or the graveyard. They're people who have discordant concentrations because pathologically their LDLs are either small or they're carrying too many triglycerides, which they should never carry. Now, by the way, just to solve this debate, I am not saying that big LDLs are cardioprotective and small LDLs are not. What really drives an LDL into the artery wall is particle number. Once you exceed a certain threshold in the plasma, the liver can't clear them. So where do they go? They invade the artery wall. So particle number is the number one driving force of at least LDL particles into the artery wall. So as triglycerides goes up, there's less cholesterol per particle. The particles are apt to be smaller. There's way more LDL particles, and they have atherosclerosis. So it's particle number. ApoB would tell us that. LDLP would tell us that. LDL cholesterol may or may not tell us that. And the same would be true of non-HDL cholesterol. There's just discordance once you start screwing up the composition or the size of these particles. But remember, the most killer disease in atherosclerosis, the one where you might even get it when you're 4 years old, is familial hypercholesterolemia. They have 100% gigantic, large, fluffy, buffy LDL particles, but they have too many of them. So they crash the artery wall. So you can't necessarily say that small LDLs are more atherogenic than big or vice versa. You could maybe say that as a generality, because the overwhelming majority of people with small LDLs are insulin resistant with a multitude of other atherogenic risk factors. But don't think that big LDLs are non-atherogenic. What decides whether LDLs are atherogenic or not, the primary factor is not size, not their triglyceride composition, it's their number. So and we start with that, and then we start looking at the other stuff.
That's a very good clarification, Tom, because if you just look at engineering or just the diameter of the fluid, of the particle in the fluid, you would think that when the artery wall is damaged, the smaller particle is more apt to get in rather than a bigger particle. But from what you're saying, it doesn't matter. They're both small. And
look, it's like all of these paradigms. There's a little bit of truth to that. Long time ago, when people were discovering atherogenics and lipoproteins, it became clear that if you had a lipoprotein that was bigger than 70 nanometers, 70 in diameter, it really could not cross the endothelial barrier and get into the artery wall. But the only lipoproteins that are that big are very big VLDLs and chylomicrons coming out of your intestine. The biggest LDL is 25 to 28 nanometers. The smallest is 18. Okay. So LDLs have no trouble crashing your artery wall. There is a prevailing thought, though, that if we just said particle per particle, might small LDLs be more atherogenic than big? There's some credence to that. First of all, everybody with small LDLs is dealing with insulin resistant. There's like 34 other risk factors in their blood that would predispose them to atherosclerosis. Most people who have pure big LDLs, there's no insulin resistance going on. So there's other less risk factors. The small LDLs are associated with diabetes, hypertension. The big LDLs are not. So are the small LDLs so dangerous because they're small or because they're associated with 15 other things that can injure your artery wall? The other thing is, could the small LDL be perhaps more inflammatory than a big LDL? So we've spent so much time today talking about lipid and lipoprotein concentrations. There's a new emerging metric. I sort of hinted at it with HDLs. I don't care what their concentration is, but I do care about their functionality, which we cannot measure. Another word for functionality is the quality. So I guess if you're an ApoB particle and you have poor quality, maybe that will induce you to go into the artery wall. So the quality of LDLs or VLDLs is related to other things apart from size. It's what enzymes they might be carrying. It's other apoproteins. It's what we call the lipidome. What are the specific phospholipids that are in those particles? So there's just so many other qualities of lipoproteins that may contribute a bit to atherosclerotic potential. So I think that people are nut jobs who say big LDLs are not atherogenic, only small LDLs are. But I think it's equally vice versa on that too. Mm-hmm. You just have to examine any lipoprotein concentration, not by itself, but in the total milieu of what else is going on. Yeah. So there are many things that can contribute to the atherogenicity of an LDL particle. One of the worst, I hinted that there's a lot of other apoproteins. Somebody should Google apolipoprotein C3. God forbid that's on your LDL particle, big or small. Google apoprotein little a. God forbid that's on your LDL particle, be it a big or a small LDL particle. Mm-hmm. So like every other thing in lipidology, it's complicated. There are generalities, but there are a lot of exceptions to the rules too. So, if you're going to go and get your metrics and you're going to contact a guy like me, I'll look at anything you send me, but don't ever send me a bunch of stuff without giving me ApoB first, or total LDL particle count. All the other stuff would be clue. It might help me decide, are you insulin resistant or not? Are you somebody where triglycerides have to be taken much more seriously than somebody else? So, it's complicated.
Okay. I think anybody listening to this podcast so far, I think you've hammered this enough, Tom, that you must get the ApoB test, or you must know the LDL particle number. That is very, very important for you to kind of make an initial determination even of what to do with this particular patient. Now, I got one more question on LDL. And this one is it genetic, the size of your LDL or the number of your LDLP particles, or does it come as a result of lifestyle or things that you do as you grow up?
Well, the answer is, of course, both. Look, everything in the human body has got some relation to genetics. Mm-hmm. And I think one day we're going to have some polygenic atherosclerotic risk score that when you're born or in the first year of life, they're going to analyze your genes and say, oh my God, you got 32 of these genes. You're doomed. You are the person who on line one of your death certificate is going to be atherosclerosis. And by the way, you are never going to have to worry about atherosclerosis. We have to worry about these other chronic diseases in you. So yes, genetics, of course, is what determines what proteins you make. And all of those proteins are an integral part of the lipoproteins that are floating in your body. So do you make that ApoC3 I'm talking about? Do you make that apoprotein little a? And there's 10 other apoproteins I can mention that would affect the clearance and other qualities of your various particles. So yes, but given that you have a genetic makeup, yeah, what can also distort or make abnormal various lipid and lipoprotein metrics that are related to atherosclerosis. And clearly, there are things in our environment, both lifestyle, activity, toxins we breathe in and stuff, heavy metals you might be exposed to that contribute to a lot of things. More and more emerging is what's going on with the gut microbes and stuff, which a giant part of cholesterol and lipid homeostasis involves the gut. Mm-hmm. So what other things might be going on that we've sort of ignored until now, but that are emerging? So there's a lot of things. And sometimes we don't even know. But we certainly, if we ascertain with even conventional tests that you are at atherosclerotic risk, we will ultimately probably, and I don't want to say guesswork, but advise a certain lifestyle for you. And depending on what risk category you're in, say, oh my God, it's good you're doing or not doing a lifestyle, but even if you are or not, you have crossed the threshold where pharmacology is necessary to restore a normal cardiovascular risk profile of you. So yeah, of course, what we eat determines a large part of the lipoprotein production, catabolism, and its content. But again, if you're dealt the right genetic hand, probably, and it's only a few of us, probably don't matter what you eat mm-hmm. or do you exercise or not. In general, that would be the far exception rather than the rule.
Okay. I learned something from you recently, Tom, is that the dietary fats that you eat, the saturated fat that are full of cholesterol, only 20 up to 25% of that is absorbed through the intestine into your liver, and the 75% is excreted out. Is that fair? Is that correct?
Yes, but you started off on the wrong premise. You talked about fats and cholesterol. They're different lipids. Let's not confuse fatty acids with cholesterol. Of course, we eat both, but they are handled totally different by the intestine, and they don't necessarily have anything to do with one another.
Okay.
Fatty acids, if they get absorbed, are linked to various types of potential problems. And cholesterol, if it gets absorbed, might or might not contribute to lipoprotein abnormalities. I started off very early that every cell in your body produces cholesterol. So if I could extract every cholesterol molecule in your body and give it to third degree, where did you come from? The overwhelming majority are going to say, this cell made me, that cell made me. Very few are going to say, oh, this person ate me and I got absorbed through the intestine. Some will, but the majority will not. So when we eat supper or lunch today, you're swallowing some cholesterol. Likely you're swallowing some fatty acids, depending the makeup of your diet. They're going to go down through your mouth, your esophagus, stomach, and wind up in the proximal and mid small intestine, which is where most lipid absorption occurs. So let's look at the cholesterol in the diet. Now, I didn't talk about it before. I just been using the term cholesterol. Some people might be mad at me because he didn't tell us the difference between good and bad cholesterol, as if there are two types of cholesterol. You know what? There are two types of cholesterol, but they have nothing to do with being good or bad. Good cholesterol used to be, oh, that's the cholesterol that's in your HDL particles. Bad cholesterol is the cholesterol in your LDLs. Since LDLs are doing the illegal dumping, that's bad. We didn't get into it, but a giant part of the cholesterol content in LDL comes from an HDL. So does it suddenly go from good to bad? But let's dismiss that topic for if we ever get around to discussing reverse cholesterol transport. There are two types of cholesterol. One is the cholesterol molecule I briefly described when we started this, a series of rings and a tail. That's what's called free cholesterol. But most of the cholesterol you eat is not free cholesterol. The animal that it came from stuck a fatty acid onto that cholesterol molecule. When you stick a fatty acid onto an alcohol, which is what a sterol is, that's called esterification. So if I take a fatty acid and stick it on a cholesterol molecule, it's called cholesterol, now spelled with a YL, ester, abbreviated as CE. Free cholesterol is abbreviated FC. So when you eat something, a slab of beef or anything else, almost all of the cholesterol in that is going to be cholesterol ester, not free cholesterol. Free cholesterol would be in the cell membranes of any cells in that slab of meat, but most of the cholesterol is as cholesterol ester. By the way, cholesterol ester is inactive. It's the storage form, the transportation form of cholesterol. Free cholesterol can wind up in a membrane or in a gonad and do stuff. All right, so you're eating this massive cholesterol. The only cholesterol that your small intestine can recognize, bind to, and absorb, and there's a specific receptor that recognizes sterols and pulls them in, they only recognize free cholesterol. So if you're swallowing cholesterol ester, and that is the majority of the cholesterol you're swallowing, it cannot be absorbed unless your pancreas secretes an deesterifying enzyme, which would knock the fatty acid off the cholesterol ester, changing it into free cholesterol. Those are called esterolases. And your pancreas is capable of secreting them. So you're eating cholesterol ester, but some of it does wind up as free cholesterol, which is absorbable. But here's the reason it's not. Now I'm in my little submarine, I'm in your proximal small intestine, and I see all these cholesterol molecules floating around. And I give him my questionnaire again. Yo, you, cholesterol molecule, where did you come from? Did this guy eat you and it got deesterified and that's your origin? Or did you come from somewhere else? 80% of those cholesterol molecules are going to say, oh, goodness, no, I was made by some cell in the body. I was brought back to the liver, and the liver just pumped me into the bile, and the bile dumped me into cholesterol. So remember, only free cholesterol can be absorbed. 80% of the absorbable free cholesterol in your gut came out of the liver and bile. Originally, it came out of some cell in your body. Your body was doing everything it could. Let's get it back to the liver and I can get it the hell out of here by putting it in the gut. But once the liver or anything you ate winds up in the proximal small intestine, does it get absorbed or not? First of all, most of it is going to be biliary cholesterol that's going to be absorbed. A little bit could, but that depends on that receptor you got absorbing it. How many of those receptors do you have? Is it going to pull it in? Is it not? If that receptor does not internalize any of those cholesterol molecules that are sitting in your gut, whether they came from your diet or your bile, they just keep traveling down the small intestine and sooner or later leave your anus and get excreted. Fecal sterol excretion is the major way the human body regulates cholesterol. So the intestine is an integral player in deciding, I'm letting no cholesterol in because this guy's cells are making it like crazy and they don't need it. So they shut down that membrane receptor that pulls it in. Or say you weren't making cholesterol in your cells, your gonads are screaming, I need cholesterol. Then they would upregulate that receptor, which internalizes your cholesterol. So cholesterol absorption is almost all reabsorption of internally synthesized endogenous cholesterol, not eaten. The only people who perhaps have to worry that I've eaten too much darn cholesterol were those who genetically overexpressed that sterol absorbing protein. It's called the Niemann-Pick C1-like protein. And if you have genetic hyperabsorption, that might be the one person we'd say, hey, cut down on the cholesterol in your diet. But that can be measured. There's a blood test that measures whether you overabsorb cholesterol, or you could just see, I'm eating 14 eggs a day, my LDL cholesterol went through the roof. Clearly, might be an overabsorber. So it gets complicated.
Okay, well, thank you for that color commentary on what's actually happening when you eat and through the intestine. The other question I would have regarding this, Tom, since cholesterol is not coming through the diet, it's not, or at least through what we eat.
In most people, right.
In most people, so it's being endogenously produced by the cells, the peripheral cells or the liver cells in our bodies. Why is there, and I this is an assumption on my part, that most people over 40 or 50 or a certain age start to have high levels of these cholesterol in their body, which leads to all these atherosclerosis and other things. But why is there so much cholesterol being made and trafficked within our body and not being excreted?
Well, number one, let's go to any cell in your body. What does it use to make cholesterol? If it's a 35-step process, what does it start with? Basically acetate, small, very carbon. So fatty acids in the liver, in any cell in your body are what induces cholesterol synthesis, and saturated fat being worse than other types of fat. So if saturated fat makes it into your cells start over synthesizing cholesterol. Now think you're a cell and the burger alarms are going off. It's like if your cellar started on fire right now, you'd be screaming, I got to get this out. So when your cells start over synthesizing cholesterol, there are what we call nuclear transcription factors that recognize, oh my God, we're progressing towards sterol toxicity. Luckily, they have the capability of telling that cell membrane, upregulate this transporter that effluxes cholesterol out of the damn cell. Therefore, it will not crystallize and kill us here. And that is called an ATP binding cassette transporter, A1. There are others, but that's the primary one. So if your cell is making too much free cholesterol, it goes to that transporter, which pumps it out one cholesterol molecule at a time into something that will accept cholesterol in your bloodstream, ApoA1, your HDL protein. So especially unlipidated ApoA1 are very small HDLs. Yo, cell, you want to get rid of cholesterol? I'll take it. So cholesterol goes right into those eensy-weensy HDL particles. It undergoes a chemical reaction. Guess what? It gets esterified with a fatty acid, becomes cholesterol ester, which goes to the core of the HDL, and the HDL starts going bigger. And before you know it, you got big HDLs. So if that's happening all over your body in your plasma, that's the first safety mechanism to get rid of sterols. Look, if your cell, for whatever reason, is just producing too much damn cholesterol, you overwhelm that system, that cell dies and morbidities occur. So what does the HDL that technically just took all that cholesterol out of your cells do with it? Well, we are in its simplicity. We're told it races it right back to the liver. That's what reverse cholesterol transport is. Not quite. What it does is now you have an HDL full of cholesterol. It's happy to dump it anywhere. What might be the first pit stop of a big HDL full of cholesterol? Hey, gonad. Hey, adrenal cortex. You guys need any cholesterol?
Right.
The major source of cholesterol for gonads and other steroidogenic tissue, other than de novo synthesis, is delipidation of HDL particles. That's a major function of HDLs. Hey, we'll take this cholesterol that cell didn't want, but these cells do want it. But sooner or later, your gonads or your cortex will say, that's it. We don't need any more cholesterol. So they downregulate the receptor that delipidates HDLs. Where else can the HDL bring it? Everybody knows our adipocytes are big, fat triglyceride storage organs. Well, not really. They're lipid storage organs. Guess what else is a giant component of adipocyte cell components? Cholesterol. So HDLs can go over to an adipocyte, which has a receptor that sucks cholesterol out of the HDL. It's called the scavenger receptor B1. And your fat cells start filling up with cholesterol as well as triglycerides. Why is that important? Suppose tomorrow you got bit by a rattlesnake, you're going into crisis, hypovolemic shock, systemic shock. What is the one hormone you need? Cortisone. Your adrenal has to make it. Where would your adrenal get an emergency supply of cholesterol if it needed it? Little baby HDLs go over to the fat cell, they extract the cholesterol and they rush it to the adrenal gland. You can see these homeostatic mechanisms are like fingers that are interlocking. Yeah. But finally, let's say you didn't get bit by a rattlesnake. You got these big HDLs. Now their mission is, let's get it into the stool because this is excess cholesterol. We don't want it to hurt this person. So here's what they do. 3 avenues. One, bring it right back to the intestine itself, bypass the liver. The liver can extract, the intestine can extract the cholesterol, pump it out into the gut lumen, you poop it away. That's called trans-cholesterol efflux, an emerging process, just beginning to be understood. Here's the conventional pathways. I'm a big HDL full of cholesterol. Let me get it back to the liver. 2 avenues. One, I'll bring it right to the liver myself. The liver has a couple of receptors that can grab that HDL, internalize it, or delipidate it. So the cholesterol goes from the HDL into the liver. When you take cholesterol out of the HDL, what does it become? A small, weensy baby HDL again. It can rush right back to a cell and gather more cholesterol. And HDLs have a 5 to 7 day half-life. They fill up, empty, fill up, empty. All right. But what is the other major pathway? By the way, if an HDL brings it back to the liver, that is called direct reverse cholesterol transport. All right, but here's another option. What do I want to go back to the liver for? I want a shortcut. HDLs, you have 18 times more HDLs than you do LDLs. HDLs bump into your LDLs. And they say, yo, LDL, buddy, we both work for the same lipid transportation company. Can I give you my cholesterol and you take it back to the liver for me?
Oof, okay.
The LDL says, sure. And Mother Nature, evolution, has given us a lipid transfer protein, which actually traffics with the HDL. It's a tube that extends from the HDL, penetrates the LDL, and cholesterol ester in the body of the HDL moves over to the LDL. Oh, it's like they're having sex with one another, stop the bodily fluids. So now, and this is the joke about good and bad cholesterol, a cholesterol molecule that a few seconds ago was in your HDL, that's good. Now it's in your LDL. Oh my God, is it bad? Depends what the LDL is going to do with it, isn't it? Right. If the LDL decides to go crash your artery, that's a stupid mechanism. But what if the LDL binds to an LDL receptor in the liver and gets internalized? The LDL completed reverse cholesterol transport. Most people don't know. Probably the primary function of LDLs is to bring cholesterol back to the liver. And as long as you don't have too many LDLs and you got enough expressed LDL receptors, they're cleared. That lowers ApoB, it lowers LDL cholesterol. Then the liver has options of what to do with that cholesterol. It can go in a bile, convert it to a bile salt, put it right back in a VLDL, which is going out, or help fill other HDL. So it's complex. But when an LDL accepts cholesterol from an HDL and brings it back to the liver, that's called indirect reverse cholesterol transport. So now if we want to seriously talk about reverse cholesterol transport It's the sum of direct reverse cholesterol transport, HDL mediated, LDL cholesterol transport indirect, and however much transintestinal cholesterol efflux you have. And I'm going to end this whole complex story that when you measure a serum HDL cholesterol level, it tells you absolutely zero about which of those mechanisms is going on. It's not related. You could have high HDL cholesterol and have none of those pathways working. You could have very low HDL cholesterol, and that just means all those pathways are working fantastically. So I cannot look at your HDL cholesterol as so many uninformed doctors do and say, you have great reverse cholesterol transport. I would gag if somebody said that. And patients got to understand that. Women for decades were told, oh, your HDL cholesterol is higher than men's. You got great reverse cholesterol transport. You're protected. Intuitively, if HDLs are dumping cholesterol in the liver, that means they're losing their cholesterol. Why should HDL cholesterol be going up? Think about it.
Thank you, Tom. By the way, that was a very storyboard framework where you walked me through it all, and it made perfect sense. There's particles having sex with each other. There's baby HDLs. They're not coming from the sex, but they're just independently baby HDLs. So really cool story. Now, I do want to get into the brass tacks of how to lower these bad numbers, but we'll do a small pit stop at atherosclerosis, which we've talked about multiple times in this podcast interview. And you've told me that or not you've told me, but I believe that it is one of the major causes of heart disease in our country. And so the question I have, we've talked about LDL particles and the cholesterol on the LDL particle that's so dangerous, but both of them are what's causing crashing into the artery wall. Is a necessary and sufficient condition of all this atherosclerosis or the plaque forming, is that the artery wall has to be damaged by some other mechanism before the LDLs can crash in, or can they crash a regular good functioning artery wall by themselves?
Actually, as it turns out, they can. There's a tremendous paper published this year. It's called The Changing Landscape of Atherosclerosis by world expert Harvard professor Peter Libby, who better understands atherogenesis for the last 30 years than anybody. And it's become evidently clear now that LDLs can transcytose endothelial membranes without any inflammation being present. Wow. So it's not necessary to have inflammation. But the truth is, most people do have inflammatory processes going on. So it's a combination of both. But the true answer is LDLs pass through the endothelium. They bind to proteoglycans in the arterial wall. We used to also believe that then they have to be oxidized, which is why our blood vessel wall macrophages internalize them, creating the foam cells. We now know that almost all of that data about oxidation came out of mice cells and may not apply whatsoever to humans.
Oh, wow. That's huge.
Although oxidative forces are bad news, the oxidative lipids are pretty much toxic moieties. That's probably not the primary reason why LDLs are being internalized by the macrophages in the artery wall. They now call it LDL aggregation. The more particles that wind up through your endothelial barrier, and they believe there's a process called caveolin, which is part of an endothelial membrane that grabs the particles and just sort of, it's like a bus that brings them through the endothelial cell and puts them into the intimal layer where they bind to the proteoglycans, the ApoB. If you get enough LDLs binding, they aggregate and they become messes. And that's when the white cells come over and eat them. Once the white cells eat them, they start secreting all these cytokines and growth factors that contribute to the inflammatory milieu that's going on. But we also know, say you had chronic rheumatoid arthritis, lupus, other autoimmune diseases, they have seriously high incidences of atherosclerosis. So you would think that, yes, if for other reasons you have endothelial dysfunction or things going on, you really don't want to have too many LDL particles.
Right.
And we haven't give VLDLs there, but there are other qualitative aspects to the VLDLs that make them very proactive. It's not their number that drives them, but it's the apoproteins and other lipid moieties they're carrying that makes them so dangerous. But at the end of the day, what's a VLDL carrying? Cholesterol. So,
okay.
So I'd be a fool to say don't ever worry about inflammation. But listen, we've had lots of heart disease where there's, at least for the routine markers we use in practice, none of the inflammatory markers have elevated. They may be, they may not be, and it's probably worse when they are.
Mhm.
So we've also had powerful antioxidant drugs as well as antioxidant vitamins tested in clinical trials and have had no impact on atherosclerosis.
Wow.
Google succinylbucol, which is a
Mhm.
powerful antioxidant drug, did nothing in a clinical outcome trial. So inflammation is part of the picture, but it's don't ever downplay ApoB or LDL particles because there's no way you can determine inflammation.
Right.
I don't
Right.
think we have the proper biomarkers in most people to tell us who's got an inflammatory milieu or not. I mean,
Right.
there are ones that give us clues, but they're not
Mhm.
always abnormal.
Right. The
Oh,
high
yeah,
sense.
it's important. And that's why I think lifestyle is going to be part of our solution. But the quick answer to your other question, if it's ApoB particles are such an important part of this process, just don't have too many LDL or other ApoB particles. And the best way to do that is to clear them before
Mhm.
they can create havoc. And that means upregulation of the LDL receptor, which binds to these ApoB particles. And what are the drugs? Virtually all of the drugs we now use in high-risk people to work through the LDL receptor. Yeah, there are some others for these genetic lipidoses that affect very triglyceride-rich particle synthesis and everything, but most people don't have that would be a triglyceride of 1,000 type of disorder or something.
Okay.
So it's clearance, induced LDL receptors, statins, ezetimibe, bempedoic acid, PCSK9 inhibitors, and lifestyle.
Tom, if we could, I love this. This is the last portion we're going to talk about in this extended interview. So thank you. What I want to do is maybe break it down per marker. If there are differences or if they're all same, you could just say it applies as the same as above. But if you could go down to what people understand, meaning LDL cholesterol, is there a way to reduce LDL cholesterol or it all goes back to ApoB?
Yeah. Where is LDL cholesterol? It's a component in ApoB containing lipoproteins, most of which are LDLs. So the easiest way to get rid of them is clear, induce LDL receptor upregulation, make your liver produce more LDLs. They will grab those ApoB particles, internalize it. Maybe they excrete it into the stool via the bile or change it into a bile acid and put it into the intestine. So that's the best way. That's the everyday way. All of those drugs I rattled off work by either making the liver produce more LDL receptors or make the LDL receptors you have last longer. That would be the PCSK9 inhibitor. So that's what they do. These drugs have slight influence on the production rate of ApoB particles, but that's a small part of controlling plasma ApoB. You know, and this is where, okay, if I reduce triglycerides via lifestyle, yeah, it's not that you're producing less VLDLs, you're producing less big VLDLs, and their catabolism is much more rapid. So they change rapidly into LDLs, not excessive amount of LDLs, and those LDLs are cleared. But once you put triglycerides, you delay the catabolism of all those ApoB particles, which drives ApoB through the roof. So,
okay, so reducing triglycerides is a valuable metric in this game,
especially in these insulin-resistant people, which is what drives that discordance I talk about. So, yeah. So, and we can do that. There's all sorts of lifestyle ways of doing that. And there are some pharmacologic ways of doing that too. So, but I mean, I know if you're insulin resistant and you do have triglyceride-rich lipoproteins, I guess I could drown you with a lot of drugs that would help you with your ApoB, but it'd be a lot better. And maybe I could use less drugs if you contributed to your own lifestyle. That means I have to come up with a diet that's capable of doing that. And I'll let you interview dietitians that'll tell you how to do that. And whatever diet you pick, and I think most of us, if we encountered insulin-resistant people driving ApoB with all those particles, we'd probably putz with a low-carb type of diet. Not necessarily ketogenic, but low carb. Maybe if you want to go ketogenic, you could try it and see. And we might see what happens to any of the parameters or so. And no matter what diet you choose, whether it's just low carb, Mediterranean type of low carb diet rather than ketogenic low carb diet, do me a favor and repeat the lipids and lipoproteins in 2 months and seeing, is it not only effective in getting rid of these risk factors we identified, but is that diet doing anything bad to some of your lipid or lipoprotein metrics, in which case you might want to rethink it.
Okay. Now the
So
interesting
trial and error.
Yeah, I love that, Tom, because it's so individual for people. But coming back to something you've said multiple times is that people that are insulin resistant can be discordant in these numbers. Are there effective metrics that you use to track who is at a risk or already has insulin resistance?
Apart from lipoproteins, or I mean, there are many lipoprotein signatures of insulin resistance. It's too many of the small LDLs, too many of the big VLDLs, lack of big HDLs. So there's any number of things you can order on an advanced lipoprotein profile that would say you're likely dealing with insulin resistance. But look, we have insulin sensitizing agents, which all might help reduce some of the pathologies related to persistent insulin resistance, be they glycemic or not. By the way, some of those metrics would even raise LDL cholesterol, such as GLP-1 receptor agonists or the SGLT2 inhibitors. They can raise, although they're combating insulin resistance in many ways. So you have to understand whatever drug I'm using, what might I expect in a subsequent lipid or lipoprotein profile. But there's many ways to skin a cat beyond lifestyle with these insulin resistant people. So very quickly, if I'm a layman and last week I had a lipid profile, what would suggest to me that you're dealing with insulin resistance? Maybe or maybe not your waist size. It's a clue, but it's not mandatory. Do you or do you not have hypertension in general? Even have subtle hypertension, that would be a clue to me. But I guess a glycemic abnormality would, but you don't have to necessarily have it. Other people would advocate a glucose tolerance test, or at least a 2-hour postprandial glucose might give you more information. And then there would be people that say, hey, I'm doing insulin levels also, because if you're insulin resistant, at least for a long time, your insulin level goes up before your beta cells die, and then your insulin disappears. And there are other metrics that we can use that might clue us in. But if I want to pick up a lipid profile, the fact that your triglyceride is starting to go between 100 and 130 makes me think I could be dealing with insulin. If concomitantly with the triglyceride escalation, your HDL cholesterol is going down, by the way, the reason that is because triglycerides are now invading your HDL particle, knocking cholesterol out of it. So of course, HDL cholesterol goes down when triglycerides goes up.
Right.
Some people use the triglyceride HDL ratio, which I think is silly because it varies among ethnicities, but as trigs go up, your HDL cholesterol is going to go down, which would make that ratio go high. So those would all be clues. A normal LDL cholesterol, but a high non-HDL cholesterol would be a clue.
So let me ask you something else, Tom. Thank you, by the way, for that. If I'm a normal person and I don't have metabolic disorder or insulin resistance, by the way, if you do, you want to get rid of that, you want to tackle that, because insulin resistance or high glucose over long periods of time leads to insulin resistance, which leads to metabolic disorders, diabetes, and all the other dysfunctions that follow that. So get rid of that as quickly as possible. But a good way is eating low carbs to begin with.
Most people start there, yeah.
Yeah. Now, the flip side, if I don't have any of those metabolic disorders, I'm just a normal person and I'm looking at my numbers and they're starting to edge up a little bit at some of these metrics or numbers that you've said, I'm not comfortable with them anymore. Where do I start? Are there non-pharmaceutical ways? So could I do fish oil? Could I do supplements to help start reducing this other than diet or in addition to diet? And what might that combined approach look like?
Look, I think if you have abnormal lipid lipoprotein metrics and it's not obvious that you have insulin resistance, you have to do more of a workup. So are you a hypersynthesizer or a hyperabsorber of cholesterol? There are blood tests that measure that. And if you're a hyperabsorber, not much you can do with that dietary wise, because most of the cholesterol is endogenous that you're absorbing. If you're a synthesizer, you could try reducing saturated fat content in your diet. That works for some, not for everybody. And again, if I did the blood test to tell me you're at a hypersynthesizer absorption, it might clue me in. If I decide I need drugs because your synthesis is out of control no matter what you eat, what are the two drugs that inhibit cholesterol synthesis? Statins and the new bempedoic acid. And if I find out most of your problem is you're overabsorbing gut cholesterol, then ezetimibe, the brand name used to be Zetia, would be your drug of choice for that. In some people, I might do both because you get even better results. If it's purely LDL receptors, all of them would work. If I don't normalize it, that's when you reach for the more powerful PCSK9 inhibitors. Say you decide there's a little bit of hyperabsorption, hypersynthesis, but you don't have plaque in your arteries yet, so that person doesn't want to take a pharmacologic therapy. You try whatever the hell diet you want, and 2 months later, see what you're doing. The guidelines would tell you restrict fat in your diet, and that's fine. It might work. Try it. If it works for you, great. If it doesn't work for you, I don't think you have to stop fat in your diet. Per se, you can get into the discussion, are there some fatty acids that might be more helpful or less hurtful than others? The Mediterranean diet advocates would tell you, yes, dump the saturated fat and stick to the poly, or monounsaturated fat might be a better way to do that. Even if you wanted to go keto, there are plant keto diets that you don't have to drown yourself in saturated fat. Or you could do keto, which may cure everything and does not screw up your ApoB. And that happens in many people. In some people, it does screw it up, and that's a warning sign to me. So, but most of the other things you're going to try are going to be trial and error.
Wow, there's so much nuance and complexity to this field. I would submit, Tom, that this is one of the more complicated areas of our body. For you, it might not seem that way, but for me, having done my research, I'm just like, I'm barely hanging on, and you're just giving me like the smallest level of detail, because you can go 10 levels deep.
Yes, that's the scary part here. Right. This is infinitely more complex than I've even let on today.
Right. And so thank you. Thank you for keeping it so light for the audience. We'll definitely love to have you back. In case people want to see somebody who knows what they're talking about with lipids and to look at their numbers, are you available for consultations, or how would people...
Not outside of Peter Attia's practice at present. But as you mentioned, I'm quite a contributor to Twitter at Dr. Lipid. And I'm, for a thought leader, a pretty responsive guy. Now, don't ever tweet me your individual things and say, what should I do? Right. I can't practice medicine over a tweet, but I can suggest some references on concepts that you might better. And the only thing I would tell you on Twitter is, I do respond if somebody is polite and coherent in what they're asking. If it's some nut job who starts screaming at me that I'm ignorant or I don't know what they know, they would be blocked pretty quickly. So for any of you tweeters out there, keep it polite, keep it sensible. And I'll, without giving you individual recommendations, can point you in the right direction. But now I retired 2012 when I left practice, got into laboratory medicine. And I just teach a lot of doctors how to take care of this, or nutritionists, and give advice through through publications and Twitter to people. But only prayer of getting me as your lipidologist is somehow get into Peter's practice, and that's easier said than done.
Exactly. Okay. Well, thank you so much, Tom. You have lived already a rich life as a preeminent expert in the field of lipidology. And I certainly hope that you continue doing this for decades and decades, because the world needs more of the information that you're sharing so simply. And most practitioners, I would say, are not at the same level, not even close as where you are.
Yeah, but how would you expect that? I've spent my life in the lipid world. Right. And I know a subject of huge importance to you is longevity. And the real reason I'm such close, and I've known Peter a long time, is he's, as you know, a top longevity expert. And he's certainly given me, for those looking at, I'm 75 years old right now. And for the most part, the brain still functions. And so do I, other than some bum back troubles I have. So this is important stuff. And I think even understanding lipids to whatever degree, plus some of the other things you hinted at, is our best way to avoid chronic disease and enhance longevity. So that's the key, longevity.
Yeah, that is. Like lifespan and health span together, they're just the 1-2 punch that I think everybody wants, or most people want, I should say. So Tom, Dr. Dayspring, thank you so much for coming on the Anti-Aging Hacks podcast. I know we've just skimmed the surface, and I'd love to have you back later on this year or next year to discuss some more intricacies in the lipid world. So thanks again.
Very happy to do so. And you bring me back next year, we'll probably have new concepts, and I'll be saying, you remember what I told you last year? It's not exactly true. So it does evolve.
Yeah, I love that you're on the bleeding edge or the cutting edge, so you can bring some of those to bear. Thank you, Tom.